Welcome back to the Relentless initiative, where I'm always trying to bring experts and individuals that can help us live a thriving mental, physical, and emotional life. And today I have James with me.
My name is James O'Hara, and I'm a nurse practitioner with Gillett Health. And thank you so much for having me. I'm excited for our conversation today.
Absolutely, me as well. And we're going to get into men's health, women's health, having children, because you just did that. Before I do all of that, I'm always interested in hearing, especially someone in the healthcare space, kind of your journey and trajectory into where you are now and how you got started.
Yeah. So there's several, moments that were pivotal. So I started on the patient side growing up. Broke a lot of bones. So I was in orthopedic offices and emergency rooms and that sort of thing. And one particular fracture, I had a complication known as compartment syndrome, which for the audience is where basically you have so much swelling that it cuts off blood supply, puts pressure on the nerves, and you can lose the function of a limb if that happens. So fortunately, I had a good mother, got me to the emergency room, and a good surgeon that performed the release on that. It's called a fasciotomy, and I didn't suffer any consequences. I've got full use of all my limbs, and it was this right forearm here that had the injury. So for me, that was something where it's like, okay, that shifted me into healthcare in general, because I was like, wow, you can fix people, prevent things from happening. So I guess even when I think this was 8th grade summer, maybe the summer before, you can prevent negative health consequences. It sort of just stuck with me. And then the bulk of my time as a RN was spent on the cardiac unit. It was the largest unit of the hospital, where I was working primarily and seeing open heart surgeries or people coming in with strokes. Those are the number one causes of mortality, is heart attacks and strokes in the United States. And realizing that, the estimates are this is 80 or 90% preventable. That's what the American Heart Association has put out, just because there are risk factors and you can control those either through diet or exercise, lifestyle, stress, and of course, medication, supplementation. There's all these different interventions or levers people can pull. So that's sort of what pivoted me to go further my education and become a nurse practitioner, where I could go a little bit more upstream rather than taking care of people after the consequences that already happened. Those are great people. A lot of times they didn't know until it was too late. The screening, you don't have a problem until you do. And with heart disease specifically, usually people don't feel anything until they've got a 70% or greater blockage. So you've kind of got a decades-long runway where a problem can be detected, but generally it's not until it's too late. So I guess that's the very beginning, and then the more recent trajectory. And now I like to think about patients as individuals, kind of what is the best plan I can build for a single person, looking at their values, their health status, what their goals are, and putting all that together.
Such a similar story as myself, and so many people that I know. Exact same way with me. I had asthma really bad as a child. And I coming through that, I thought I wanted to be a nurse. And then coming through more of my story, we'll get into later, I knew as well I wanted to be on the preventative side. But very, very interesting. So now you have just had your first child. Is that right?
Yeah, that's right. About 2 months ago at this point. Healthy little boy. He's doing great. We're doing great. Myself and my wife. She's been amazing. But we would both tell you the sleep leaves a little bit to be desired.
Welcome to the club.
Yeah.
Because mine are now 25 and 21, and you still lose sleep. It's just for different reasons. So
Sure.
the worry and the care is still always there. Your situation is just constant local care. But
Yeah, for right now.
So let's get into topics surrounding parenthood. And for better or worse, the internets and the Googles have so many things to show us and tell us. Often it can be great and informational. And one of the videos I came across, I think I sent that one to you, was a guy starting to understand the contribution his health has to the pregnancy and the baby's health, which is so often left just not talked about. And we just think it's all the woman shouldn't smoke or drink while she's pregnant. And that makes so much sense. And no, she shouldn't. But let's talk about, like I said, my daughter's 25. She's single, looking for a relationship and wants to have that healthy baby. What is it about the men's health, their lifestyle habits, their genetics that plays such a large role in the health of the pregnancy and the baby?
Yeah, I mean, your sperm health is going to be a direct translation of your physical health as a male. The healthier you are physically, generally the healthier your sperm are going to be. And, that's sort of half of the genes and half of the picture in terms of the initial conception. And when you have, say some chronic inflammation or, something like obesity that creates that, then you can have like more DNA fragmentation and more just negative things that are happening with the sperm. Talk about epigenetics, which is just, not actually changing the genetic code necessarily, but, think of like bad things being switched on and good things being switched off. And most of that does get reset during development, but not 100%, right? So if you have a father who's obese, and they've done some really nice, animal experiments here as well. But even in humans, we have data linking, fatherhood, advanced paternal age, obesity in men, to a higher risk of negative health consequences for those offspring. And even during pregnancy, your, placenta is not going to be 100% as good as it could be if the male's health is not, 100% as good as it could be. And I don't want to sort of shame people or fearmonger, but I think raising awareness is very important that, the male side of things plays a big role, and even the medications that men are taking, right? The one that was kind of shocking to me, and, it's one study, I don't know that's been replicated yet, but that the use of metformin in men was actually linked to some male birth defects. Now, it's hard to say, is that just because, these men were diabetic, so they probably had some sperm issues to begin with, or did the metformin make that problem worse than it was and create these issues? In either case, we have an abundance of, medications that are available that are better than metformin for diabetics. So to me, it just makes sense that you would remove that, probably 6-9 months prior to conception. That way it's just a non-factor. There's no question mark around it then.
Absolutely, I agree. And it's, again, with having two 20-ish children, not only is a person's morality and, beliefs important to consider in relationships, but it's their health and what they choose to make a priority and not. And so often I see couples that are in a great relationship, but one just doesn't want to give up that party life. And so drinking is obviously one of the big ones and easy ones to see. What are there some other lifestyle habits that people might have that could contribute to unhealthy sperm or unhealthy global systemic inflammation?
Yeah. I mean, a couple of things you could think as being health positive that are not so good for sperm would be like hot tubs and sauna. Really want to stay away from testicular heat. I mean, maybe even the heated seats in the car in the wintertime. I mean, it's a very small slice of the pie in terms of things that matter, but avoiding testicular heat, especially excessive testicular heat, will help with sperm production. Even testicular cooling, they've studied that and it shows a little bit of an improvement in sperm count. But the more common things are, just having, a good amount of physical activity, right? So not necessarily trying to run a marathon and being overtrained during that time period. That's going to generate some extra oxidative stress, but not just being a couch potato in general, right? So meeting those minimum recommendations, having a good, BMI, which isn't perfect, but generally correlates pretty well with somebody's metabolic health, making sure that you're getting fiber in, fruits and vegetables, the right number of calories, protein, these sorts of things. And then avoiding, nicotine, tobacco, alcohol. That's a big one because it's so prevalent in society. And, and people may not think of, smoking is bad, cigarettes, but they may not think about the occasional cigar or the 20 Zins that they're using a day, since those are so prevalent now. And those things all matter. And, medication-wise, there are things like SSRIs, statins, that can lower sperm count. And that's a discussion to have with your provider. And, is that something that's safe for someone to discontinue? And generally, you can look at the benefits and the risks. And if somebody's stable and well controlled and it's more of a preventive thing, referring to the statins, and they can come off of those for a time period and make sure their sperm capacity is at 100% of what it could be during that pre-conception phase.
I think it's kind of correlative to running a marathon. Like, we all have the ability to walk. Most of us can get up and jog or run, but none of us would go out and run a marathon without training properly for it. I mean, we could, but we would be throwing up and probably end up in the hospital halfway through. I think the same energy should be given to, like, if you're wanting to start a family, let's both, like right now, looking forward 6 to 8 months, let's get in the best physical, mental, emotional shape possible to give ourselves both the best experience and the baby. Agree?
Yeah, absolutely. I wouldn't recommend, running a marathon without any planning. And also, family planning is extremely important.
Absolutely. So you mentioned, back in your days of seeing all the heart issues, a very interesting situation my husband has been through. About 6 months ago, he had to go back. So we're in Charlotte, North Carolina. He's originally from the Ohio, Michigan area. And he went back for a funeral for his high school basketball coach that had a heart attack. And since then, I think 2 other men, one had a heart attack, another one died from a heart attack. And none of them had any idea. And I say that in air quotes because, there's so many signs. And what's interesting to me, we come from my husband even more so, but a very strict, we call it hyper fundamental Baptist background. So religion and spirituality is the hierarchy of importance. Many of those men were actually pastors. So there was definitely a lot of emphasis put on that side of life and very little emphasis put on our actual health and eating patterns and things like that. And I think aren't the statistics that men die earlier on average? And I'm always like, well, it's because there's so much ignoring or putting off, whether it be by pride or laziness of their health. So let's talk about men's heart health for a little bit, because we've gone from, we're talking to the young men getting healthy for pregnancy, but as they age into those 20s, 30s, 40s, what is it you're looking for? What are some signs and symptoms that, like, for example, my husband, tall athlete, but you can't ride that train all the way through your 50s and 60s and expect it to be the same as it was when you were 20.
Yeah. Yeah. And being an athlete, being in good shape and exercising is certainly important. But I mean, the bottom line to me, when I think about heart disease in a traditional sense, like plaque building up in arteries and then someone having an occlusion that leads to a heart attack, that's the most common type we're talking about. If you see like ASCVD, that's what it's referring to. We have the technology to where there should virtually never be a surprise event. People can get, it's called a CCTA or coronary angiogram. And this is a little bit better than a calcium score. A calcium score could be a good test. It's got a shorter, I call it a warranty period, maybe 5 or 10 years. If you get a calcium score 0, you're probably a very low risk the next 10 years of your life. But you don't have any calcified plaque until you do, and it's a late stage finding. So with a coronary angiogram, there's contrast dye that's used, and they time the images they're taking of your heart and the arteries when that contrast dye is in there, if it's done correctly. And that will show you if you have any soft plaque that's starting. And I'm a little bit of a stickler on how granular the reports are. So if somebody gets one of these done and the interpreting cardiologist says something like, well, there's no significant stenosis. If you're 40 years old, you want to know if there's any stenosis whatsoever. So what I'll do is have our staff call back and ask for CAD-RADS clarification, and people can look up what that means. But basically, if you get a CAD-RADS 0, that means there's 0 visible plaque. In CAD-RADS 1, you won't feel symptoms. CAD-RADS 2, you won't feel symptoms, but you could have up to close to a 50% narrowing and be CAD-RADS 2. And then that gives you the sort of binary decision of, do you want to be more aggressive in managing this, or do you want to watch and see? And my recommendation is to be aggressive and manage it. And sometimes having that data saying, hey, I have early stage heart disease, and the trajectory for most men with this is going to be an event at some point. That can be a powerful motivator for people to have a little bit more balanced in terms of their pillars of health, right? Spiritual health is very important, but you also have your, physical health. So, things like getting outside, what food you're putting in your body, exercising, your social health, all these things really matter.
What are some, because men are so notorious, again, as a body worker, I see this almost every day. Men come in and have, my back locked up, my sciatica is flared up, and I'm more than just a massage therapist. And so I start going through some muscle testing and give some recommendations. And more times than not, the response I get is, yeah, I'm not doing any of that. Can you just massage and make it feel better? So there's definitely a compliance part of it and an awareness part of it and a willingness part of it on the men's part to be aware of what's going on in their body and in their, how they, because we get used to not feeling well when you're not healthy. So what are some visible or like habit or things that can be seen in someone that is in these early stages of an unhealthy heart, like sleeping or snoring or things like that?
Yeah. And it's sort of a product of the society we're in, right? People want the quick fix. They go in and get their quick chiropractic adjustment or they want the massage, but they don't want to do the essentially, like the home PT that's prescribed. Like, hey, this is how I, put you in a better spot so where you're not coming back and not having pain every day, that sort of thing. So, that's the age old question of how do you get people to do what you want them to do?
Yeah.
But as far as that's what's problematic is you don't feel when your ApoB cholesterol, like your cholesterol lipid panel, you don't feel when those things are out of whack until it's very late. You don't feel generally the high blood pressure, right? They call it the silent killer. Now, when you become like diabetic initially, that's something people feel, but you won't necessarily feel pre-diabetes. So these are things that unfortunately you really have to look at on blood work. Otherwise, you're not going to really see it coming. People are like, oh, I was perfectly healthy until I hit, insert whatever age here, 40, 45, 50. And then they're like, the wheels fell off. There's things you can see before that, just like plugging your car into the machine at the dealership. They look and run through the computer system and they're like, hey, this sensor is telling us that we have this problem, or we know that based on the mileage, we should check this, those sorts of things. But really the initial, I guess you could call it the canary in the coal mine for heart disease is, erectile dysfunction. So if a guy develops that, doesn't matter, what age necessarily, but especially in men that are under 45, that's generally going to be a sign of heart disease. Now it can be other things too, but a lot of guys, now we have these telemedicine, I guess I could use the term pill mills, where they can go and get their Cialis or Viagra and they're treating the symptom, but that was a warning sign. Whereas if they went into their primary care doctor and had this discussion, then they could say, we should probably make sure this isn't something with your heart, since it is an issue of blood flow and build plaque in arteries everywhere, including the ones that supply blood for erections. And a lot of guys don't want to have that conversation, especially face to face. It's way easier to just click a couple boxes and get things online. But if someone's listening to that and that's them, they should talk to their doctor about getting some heart health screening done. CCTA is probably the gold standard in my mind. Carotid ultrasound will also pick up some plaque, but it's more difficult to track over time. So that one doesn't have radiation, doesn't have contrast. Cost is going to be a bit lower. And that's important for some people. So, cash pay, you may be looking at $100, $150 to get a carotid ultrasound. And that's a reasonable screening that could pick up some soft plaque. And there's a good, but not perfect correlation with, the plaque in this artery here and the plaque in the arteries that supply blood to your heart.
And as a body worker, those things always ring true for me visibly and in palpation, because especially if they're starting to gain, weight and different things like that, and they come to me for a tight neck, but they have, larger fat cells there's all kinds of stories there that come into play with, toxin load and viral loads and things like that. But if it's a weight contribution, there's literally like they're squishing the blood supply and lymph movement around the head, face, and neck. So those visible signs are important. And the erectile dysfunction is a big one because, and coming back to relationships and marriage, you have to go into these things knowing you have the negotiation ability with each other to say, listen, we're in this together. We both need to be on the same page health wise, and we've got to work through this. So I hope people will. It's hard to get the guys to the doctor sometimes. And I'll give you a story on that. So like I said, my husband's tall, athletic volleyball player, or basketball player. I was a volleyball player. And and again, this is most men's story, is that they don't ever go to the doctor. Like most of the time they go, it's because their spouse encouraged them to go or told them to go because they're not sleeping well, or it's like, this is we're coming to a head here. I'm coming through my story. I had ovarian cyst and I had a right ovary removed from a borderline cancerous tumor. So my whole health history is a story, and he just kind of flies through life through his 40s and no problems at all. And I'm like, dude, I get it, but we got to get some kind of testing and just see where you are with everything. And we've always erred on the side of functional medicine and things like that, because that's, again, he hasn't been to the doctor since he was probably a teenager. So I got him an appointment with, I'm very big on referrals, and I got a bunch of people that have been to this place. She was an MD, functional medicine doctor, and this is where you go back to where you were talking about testing earlier. I want to talk about this because there's a spectrum of like where someone can go, get good testing, get good results read from that testing, not get testing at all because it's not covered by insurance. So there's a quagmire of, especially if someone's not in the health system, to even just get started. Like for him, so I sent him to this functional medicine doctor, and a couple $1,000s later, he walks away with like a stool sample, a urine analysis, some blood work, some food sensitivity testing, and he comes home with all these boxes. And again, he's like, I'm not doing this because there's really nothing wrong with him right now. So what is your advice to people on how to start navigating? Because they do need the testing. But again, like if they go to their primary care, nothing's really wrong, they're not going to get approved to get any testing. If they go to the in and out clinics like you were talking about, they might not get the right care there either. So how in the world do we help people navigate a good provider?
Yeah. I think it has to be bite-sized, right? So it sounds like your husband was a bit overwhelmed by the degree of testing, right? And I think a lot of people would balk at several $1,000s of testing initially. So, bite-size is, a good blood work panel. We do have self-service labs partnered with LabCorp. They do the blood draws, and people can get their report. And now a lot of people run it through ChatGPT. You should go and talk to your primary care doctor or a healthcare professional about the results. But people can get a good idea of kind of what's going on just with a good blood work panel like that. You mentioned snoring earlier, which I think is really something people just think of as benign. And most of the time, that's not the case. So you can have snoring without sleep apnea, but more often than not, you have a sleep apnea, which is going to affect your, sleep quality, your energy levels during the day, your insulin sensitivity. It's going to make it harder for people to lose weight. It's going to affect your family's sleep too, right? If, dad's upstairs snoring like a bear and everybody else is being kept awake. And that's another good use of telemedicine. You can now for probably less than $200 get a home sleep test and treatment within 2 or 3 weeks if you have sleep apnea. Whereas before, several months, people would have to wait and then go sleep somewhere different, get wired up to all these things. And in certain cases, they're still going to require that. But, it's much better now. I had a patient who told me the story. He went and had a sleep study done, and that happened to be the night they had a fire drill in the hospital, right in the sleep center. So everybody marches out in the hall with their electrodes wired up, and it's just not a good experience. Looks back and laughs at it now, but in that moment, you're like, this is ridiculous.
Yeah, absolutely. And that's, again, with what I do in bodywork, I deal with so many chronic pain clients, and they have been through their PCP, they've been through neurologist, and I kind of have a very, I don't trust the medical profession very well from my own story too, but they've had all these scans and tests, and this scan is fine, that scan is fine, this blood work is fine. And they're like, and I know you know this story, I am not fine. And I can feel they're not fine on the table. So several years ago, it was a little easier to refer people to like a functional medicine doctor or someone like that. But now I'm in Charlotte. I'm in the banking center of America. So it's a well-populated, high-income area. So now it's like the functional medicine doctors legit are like membership based and between $5,000 and $10,000 to get started. The typical person is not doing that. So I just not knowing what to do, but trying to get them to understand they have to do a little something and investigating on their own. That's what I started doing, is sending them some of the telehealth sites and that seem reputable and, have doctors behind them, so that you think that's a good place to at least start. And then what I was telling people is like, just do this starting place of this test. And then if you see a really red flag, then okay, then go do the couple $1,000 investigation journey to figure out what's going on.
Yeah, I think that's reasonable. And I don't know, can't speak for other clinics, but it is a lot supply and demand as far as, the cost that's there. And I think we offer affordable, one-time a la carte visits where people can just get that basic blood panel, get in like a true opinion. You're not making up a problem for somebody, which has been a problem in functional medicine in the past. A couple of bad apples will sort of mess with the reputation of functional medicine in general, right? But there are really good providers out there, physicians, whether they're DOs or MDs or nurse practitioners or PAs, people that actually have put the time in and that care about people and want to help them solve that problem. Because there is a lot of, medical gaslighting, right? Where it's like, you're fine, or 100% of the person's problems are blamed on weight or whatever chronic condition they have. But regardless of those factors, there are always things you can do to build towards better quality of life, or, improving symptoms in the short term while you're trying to uncover, what is that true underlying cause, or what changes do you need to make to start building towards that better quality of life, which is what most people want at the end of the day. Is the health span where they feel good for a long period of time, not that they live in chronic pain until they're 95.
Yeah, absolutely. Before we transition into women's health, because that's like an all-day podcast, kind of breaking from the men's health and having a child, I've seen more and more, and again, I hear this from my clients, more children are being born with movement disabilities and improper growth patterning, unable to walk. So later, a site that I follow, she's a physical therapist. All kids are perfect. I don't know if you've come across her profile yet, but these children are severely underdeveloped beyond like walking late, beyond that, like severely. So what is your opinion of, or are you seeing more cases where people's health is worse as adults, but then also in our children, like birth defects, slow progressions of where they should be walking, talking, eating, things like that? What is your sense of the environment right now?
Yeah. So, I don't see a lot of young pediatrics or newborns, in my practice directly. I see 99% people that are 18 plus, but I have a general sense of, I guess, that area. And, having a kid, it's something you really look into and think about. And I think it relates a lot to screen time, and not just screen time for the kids, right? I saw a paper, I think a week or two ago, that the parents' screen time is actually interrupting the development of their child, that interaction where, they should be making eye contact and smiling and doing these things. And they are, on their phone, or they're watching TV, and, the kid is kind of developing in not the most rich environment, I suppose. So that's a factor. And then you'll have, some babies that probably with gestational diabetes, and, a mother who at baseline starts as overweight or obese. You're going to have a large for gestational age baby, more likely to have, a C-section and miss out on the, microbiome benefits there, and sort of squeezing everything out of the lungs through the birth canal. So there's a whole host of things going on there. But when I think of, screen time, and it's not that every single bit of screen time is bad. There are some educational things that can be used at certain points in time, but I think really just unplugging and being connected with kids is what parents need to do, and being aware of what those milestones are. So most kids are going to a pediatrician, or some form of healthcare, and they should say, hey, at this stage, baby should be rolling over, at this stage smiling, at this stage babbling, at this stage walking. And I think it's fun to kind of aim for hitting those things earlier, and like looking at like what can we do to create the best environment. And on the opposite end of the token, there's some people that will say, well, it's all genetics and the environment doesn't really matter all that much. I don't know beyond a shadow of a doubt what the percentages are there, but that's kind of a negative outlook to have. So I tend to like the idea that the environment that you're in, and trying to raise your children in the way that you want them to be raised. And people have to use daycares for certain reasons, but you do have to put in an effort to try and create a stimulating, engaging environment when the child is in your care and not in someone else's care. There are things that are out of people's control, but there's always those windows of time where you can put in that work, I think.
Absolutely. So let's talk about the mother's health. And you mentioned their, gestational diabetes, going into pregnancy, insulin resistant, pre-diabetic, diabetic. What are the effects on the baby in the womb, and as it comes into life? What is its constitution, to use a naturopathic term? Like, what's its starting point given the environment of an insulin resistant mother?
Yeah, I mean, the simplest way I think about it is that the baby is going to grow up more prone to childhood obesity, more prone to adulthood obesity. And that's, something that, I suppose if you look at the last 1 year or 2 years of data, has like plateaued or regressed a tiny bit with a lot of the medications that are out. But it's like for the past 30 years, at least, has grown and grown and grown in the United States. So it's sort of this snowball effect where you have parents that are less healthy, offspring that are less healthy, and then that cycle is sort of just repeating itself. And, the tide, I think, more people with, access to things like podcasts and taking an active interest in their health. And, I think running is now like an all-time popularity. People are like interested in doing something physically active. I think that tide will turn and we'll sort of start seeing some improvements, but that's the biggest thing that I think of, and even, medication usage. So you look at, how many people just take an antihistamine and don't think anything of it, or they're on their SSRI and their OB says, yeah, they're this category, they're safe, you don't need to worry about that. You really have to balance the known benefits you're getting from that medication, right? Because people know how medications affect them, versus the known and unknown risks. And there's probably more unknown than there are things that are known, right? So with SSRIs, you can have I don't know if you've spoken to people who have tried to go off an SSRI and struggled with that, but you basically can have a little mini withdrawal syndrome in an infant who was exposed to an SSRI its entire pregnancy, and then is not getting that anymore when it's born. So, fussiness, irritability, poor feeding, those are things that, they happen for a period of time, and then that withdrawal is over, right? The infant doesn't have access to that other than the minute quantities that might be in breast milk. So, that's something to think about. Choline is very important for the baby's brain development. And antihistamines are anticholinergic medications. So, prenatals and things like eggs are going to have a lot of choline, great for people in pregnancy to consume. But if you're sort of blocking that or blunting it a little bit with an anticholinergic, that's something that could be problematic, especially if people are using, higher doses or taking more than is on the label. A lot of people are like, yeah, one Zyrtec doesn't work for me, I take 3. That's not uncommon for people to do because they want to fix the symptom.
Absolutely. What is your opinion on in vitro fertilization is more and more prevalent? Girls starting out in their puberty years getting on birth control because of heavy periods, undiagnosed PCOS, or different things like that. But then what happens is they're untreated for whatever what the cause was for those symptoms. And thyroid function is a big player in all of that. So let's say that a woman has gone for 2-3 decades with untreated, undiagnosed, recognized, like thyroid dysfunction going into pregnancy. What is the thyroid's effect on that experience?
Yeah, I mean, the main things you're going to see is it's more difficult to get pregnant and your risk of miscarriage is much higher. So, that's a reason to, make sure that thyroid health is optimized before pregnancy. And that means, your blood levels and also how you feel from a thyroid standpoint. So, energy, temperature regulation, gut motility, cognition, all these things are affected. And unfortunately, those symptoms can have multiple causes. So, it may not be the thyroid, even though it sort of looks like a thyroid case. But, looking at a lot of, I would say the good REI reproductive doctors will, before mentioning IVF or saying we need to do IVF, they'll make sure that generally they'll actually push the TSH a bit lower, below 4.5 is kind of your general population. And some physicians won't treat until it's above 10. And then, if they're trying to optimize for fertility, they'll usually push it below 2.5. It's very common. They'll start some women on generic Synthroid or, a thyroid support medication like that. So if you're looking at, REIs, I don't want to bash them too much, but a lot of times, like, they're going to jump to IVF prematurely before they're optimizing, mom and dad's health. And I mean, there's situations where things are very time sensitive, or legitimately people have tried for years and years and years. And, for whatever reason, genetic or otherwise, it's just not happening. Those things exist. But I think, if you look at the price tag on that and the motivation of someone to just do IVF, get the highest likelihood of the result that the parents probably go in wanting, right? They want a pregnancy achieved. Then it would, to me, it would be very difficult to see that person doing that ethically just over and over and over again, when it's so much easier for them to say, oh, just do IVF because it gets the outcome, it makes them more money. So I think it's sort of become a slippery slope, and it's more in vogue now. A lot of people are, they're just like, oh, I'll just, freeze eggs, freeze sperm, and then have kids when I'm 40 or 50. Not a large as far as the slice of the population, but certainly many multitudes more than would have said something like that 10 or 20 years ago.
It's another thing that I see a lot in my practice are those women who've gone through that situation. So they had the PCOS, they had a couple surgeries for it, couldn't get pregnant, did IVF, had a baby. It just happened last week. Came to me with, she walked in my office and she was literally like stuck, and side bending. And so I didn't have any injury. I don't know what's wrong. And I start asking questions, and it's this whole story. And she went through the IVF, and then she was on a GLP-1 for a year and lost a bunch of weight, but there was never any coming back to baseline of strength and mobility before all those big things happened. And I was trying to explain to her at my limited capacity of knowledge of IVF, or maybe you can explain a little bit more in detail, but when you're on high doses of progesterone, that's the relaxing, the calming, that literally trying to get your body ready to hold in the womb and all that. So there's no wonder why your L4, L5, S1 is locked up all the time. Additionally, you lost a ton of mass without ever building strength. So what effects do you think? Of course, we want babies, and I want people to have babies and do that if they need to, but we need to be conscious of the effects that process could have. Do you have any thoughts on that?
Yeah, if you look at pregnancy in general, there's a huge incidence percentage-wise of back pain and pelvic pain, and that can even happen in mothers who are metabolically healthy at baseline. So if your starting point is not ideal, and maybe if someone went on the GLP-1 before, let's say a year before they got pregnant and lost the weight, or through lifestyle, people can do the same thing. If they did that prior then and started strength training, their body is going to be in a more resilient state in pregnancy, and they're going to be less likely to have those things. It doesn't mean it's never going to happen, but you would sort of think of like, I'm going to be carrying around, maybe 30, 35 extra pounds. And like, how should I prepare my body for this? It's like your marathon analogy earlier. I think that's great, is you kind of want to plan this, and IVF kind of just puts you on the starting line right away without necessarily thinking about those other factors. So, those are the immediate things that are going to be apparent if you have a worse musculoskeletal standpoint or starting point. Then you're going to be at a higher risk for those negative musculoskeletal outcomes. And your body's going to produce relaxin as a hormone whenever you're pregnant, and you're going to have more joint laxity. It's pretty common. And then when that goes away, you do have to do some strengthening, especially like the abdominals and lower back, because that's sort of your core that it's going to be supporting you while you're doing your day-to-day tasks or while you're returning to your baseline exercise. And I think in the traditional system, it's not something that's well supported or talked about, right? They don't say, hey, after you, go and have your baby, you need to think about getting your core stable and back to where it was. Or I think there's a lot of fear around like starting to exercise in pregnancy, right? If it's not a, perfectly planned out pregnancy and then you're pregnant, there's probably some fear of like, oh, I don't even know if I can exercise or what can I do? And that's where, talking with your provider and then physical therapists and even trainers that have worked with pregnant clients, they can kind of be the guardrails. So you're doing, safe things. So you're not doing gymnastics, right? But you can do most exercises. And especially if you have a baseline level of fitness, you can continue a lot of those activities until very late in pregnancy.
It always amazes me the whole like everything has to be natural, or the opposite end of that spectrum is, medicine for everything. And often I hear pregnancy is natural. It happens all the time. And I'm like, yeah, that's true. And it will happen. But our mothers, grandmothers were also out working on the farm every day and carrying things back and forth and up and down stairs. And we have a much different experience with mobility, even just in our world today. So we do have to absolutely plan for these things better. What is your opinion? Again, I get to work on multi-generational people in my office. So I often will see, for the more regular client, the mother, but then she'll bring in her teenage athlete daughter every once in a while. And then when her mom's in town, she'll bring in her. So I get to see the mom, the grandmother, and the daughter. And I start to see this story of health that creates itself, because we know, there's generational things that happen because of the egg being in the mother and the grandmother. And one of the most recent ones that I had was, well, two. One lady, when I hear, I've always been this way, I've always been sick, I've always been frail, I always go back to, well, there's something that in utero happened, or, there's more to your story than you're just sick. And this one specific lady I think she was the last of 8 children. Do you have any thoughts on birth order and the health of the mother on that 8th child?
Yeah, it's an interesting question. And, genetics, play a huge part. And there's so much we don't know about that for someone that has this, seemingly unexplained issue, right? We can't always put our finger on, oh yeah, this is exactly why. And maybe in the future we'll be able to do those things. But with birth order, I don't have a ton of expertise in this, but my understanding is generally the firstborn gets the most resources, both like from the mother's body, thinking of things like, calciums and vitamins and minerals. And then as the resources are less prevalent, and in terms of like time to devote during development, right? If you have, one child versus having, now this is your 8th and you're devoting resources to all of them, then there's going to be a little bit less development on average. And I'm sure there's some people that do a phenomenal job raising large families. But that's on average probably what you're going to see is, the firstborn is going to get the most resources. And what's actionable about that for people today is probably, maybe wait a little bit longer in between pregnancies, right? So there's people that have, 2 children born within 12 months of each other. That's going to be hard on the mother's body, and you're going to be in a low estrogen state while you're breastfeeding, and then the fetal development is going to potentially cannibalize the skeleton of you, because the baby's going to take priority in things like calcium. And I mean, you can resistance train and get good nutrition and sort of outrun that, if that makes sense.
Mm-hmm.
But it's not going to have zero effect on the maternal health. So, that would be sort of my very simplistic advice is if someone is, thinking about that and they have the flexibility of time, right? That luxury of family planning and knowing that, oh, I don't have to, if I want 3 kids, have them back to back to back, and space things out, get their body recovered, especially from a musculoskeletal standpoint, before they go right back into that pregnancy state. Because it's natural, but it's very different. And, things can happen there that are not ideal, especially musculoskeletal, like you're talking about.
Before we move into the HRT, I don't remember who I heard this quote from, but the greatest example of being aware of all of this is someone said, puberty is a metabolically expensive event. Pregnancy is a metabolically expensive event. Menopause is a metabolically expensive event. And if you don't have enough deposits in your account to spend on those things, your experience is going to be so much more difficult. And I love thinking about it that way. So, like, that's how I talked to my daughter when she was going into that phase of life, how I talk to myself going into, I'm 48. So going into this phase of life is like, am I prepared? Do I have a game plan? Do I have my deposits put in those accounts that are going to be asked to be drawn from? And our next topic is one of those big ones. And I'll give you a little backstory for myself so you can understand why I'm a little hesitant on this whole topic and wary of being told what to do. So I had my first OBGYN appointment when I was 19. They found my first ovarian cyst. I had to have laparoscopic surgery. It went fine, I guess. Got married at 21, had our first at 2 years later. Perfect pregnancy, delivery, everything was fine. Always had a normal cycle, except for those, cysts and that first surgery. And then I think, and my health history is my family are coal mining people. So they're from the backwoods of Tennessee, Virginia. So I had a lip tie. My son had a severe tongue tie. My daughter was born without 6 adult teeth, so she had to have implants. So toxicity is definitely a part of my story. But I had the trifecta. I had asthma, allergies, and skin issues as a child. And those started resurfacing after pregnancy and delivery, but no one ever asked about those things. So after my first child, my husband and I both, I grew up, got older, stronger. My parents were told for them to move to a dry climate, and I had long, long hair, and as opposed to what I have now, all through my teenage years. And they said, cut her hair to keep the dust from around her face and breathing, and move to a dry climate. I was always on an inhaler. I would get a strep infection or upper respiratory infection multiple times a year, always on antihistamines, always on a steroid. And I just, there has to be a better way for this story to play out for me, because I was just always told to suppress, don't run, don't do PE, all those things. So then after we had our first, I'm usually always very even keel emotionally. After we had our first, I felt different. Something was off. Had an amazing husband, amazing helper, father, contributing partner, all that. My health was fine. My baby's health was fine. I did not feel okay. So I went back to my OBGYN. The only answer was antidepressant. And I was like, I didn't know anything that I knew now. This is many, many years later. I'm like, this doesn't seem right to me. This can't be right. So I got super strict with my diet, working out as much as I can. Over the next couple of months, started to feel better. And then had another event playing with my daughter. We were running around playing. I was on the floor. She ran in and jumped on my back, and I thought I was laying on a toy. I turned over, there was nothing there. So I started smashing around. Ended up having a borderline cancerous tumor, crushed my right ovary, had to have all that removed. And through that whole phase, every time I would go in for something, it's like, well, you need to have a hysterectomy for your safety and for your future health. And I'm like, that just doesn't sound right to take out my parts unless you can tell me I have cancer or there's something really bad. So every time I had an interaction, and this is different OBGYNs, I went Ohio, Tennessee, North Carolina, it was either birth control, a surgery, or antidepressants. And that's just what I got all the time. Now, I know we've come a long way since then. We're doing a little bit better. But at each interaction I had with medical care, it was always those answers. And so now, I've come this whole way and getting stronger and healthier and all those things. And I start hearing my clients talk about hormone replacement therapy and going through menopause. I'm like, well, I guess I need to study this and be ready for that next phase of life. Okay. Because it kind of just irritates me that I don't have control over it, Like I can get stronger, I can get better with my asthma and all those things. But this is like coming up to a brick wall where I don't have a choice in that happening. But what really set me up to not doubt the need for HRT, but the story that was being told and how it was being distributed is I started having female clients come in that I had been working with I've been in the industry for almost 17 years. Some of them I've had since the beginning of my career. And I had clients that I know this, you try to encourage them along and give them the information they need to be healthier, but they have to make the decision to do it. And I've been working with these people, trying to get them to do strength training or PT or different things, especially if they're obese. It's even more difficult. But when I have this client I've personally been working with for over a decade come in and say, I have frozen shoulder now, and my OBGYN said it was because of menopause. So I'm starting HRT, and I'm going to see if that helps. I'm like, well, I don't trust any of those people now, because it did not just happen overnight. Coming into your 50th year of life doesn't cause frozen shoulder to happen. So that's kind of my my not doubting of it, but what's your experience working with women in this space so far?
Yeah, it's a lot to unpack, and the story around get a hysterectomy, and then they're like thinking back to how things used to be done. They say, well, let's just take the ovaries out because we're in there, and why not? And then you're put into a surgical menopause.
Mm-hmm.
And I've had some female patients who that was their experience, and they were in surgical menopause, and put on some form of HRT, maybe not the best form of HRT, and then some women that questioned that and said, well, hang on, maybe this isn't right, and maybe they did need a hysterectomy, but there wasn't a need to take out the ovaries, so they had to find a surgeon that would do just that surgery and not a larger operation that perhaps they get compensated more for, right? Mm-hmm. Billing codes and this sort of sick care model. And I don't think that 100% of surgeons are just out to make a buck. There are very good people out there, but there are certainly some people who are going to optimize or take advantage of the system and the way it's set up. So that definitely happens. And then in terms of HRT, there are people who are making rounds on social media now and sort of claiming all sorts of, I would say, really unsubstantiated benefits of HRT, and underplaying some of the risks that are there. So anytime you're putting in hormones, even if they're bioidentical, it can have a negative impact on mood and mental health. Generally, that's not the case, right? But that's a risk that I don't hear people really talk about. In terms of like the frozen shoulder, I'm not aware of data there. Sure, frozen shoulder, you're probably going to see it more in a 50-year-old than a 20-year-old right around menopause. So it may be correlated with age more so, but not necessarily menopause. It's usually, think of like glycation, so like diabetes or particular type 1 diabetes, there's a higher incidence of frozen shoulder. Some autoimmune conditions where there's just this low kind of chronic inflammation and causes fibrosis and the adhesion of that capsule. Those things are what I think of more with frozen shoulder than, blaming it on the menopause. It's a very handy, I suppose, scapegoat if, you're just trying to find a cause, maybe not the right cause, but if someone has a symptom, you say, oh yeah, you're in perimenopause or you're menopausal, or this is because you went through menopause. And sometimes that's the case, right? Certainly vasomotor symptoms, hot flashes, concentration difficulties, mood issues, there's musculoskeletal changes. You don't recover from exercise as well. But that doesn't mean that, 100% of people should, do HRT, right? I think they should consider it, weigh the options, look at what are the benefits, what are the risks. I think it makes sense for everyone to consider it at some point, as long as there's no strict contraindications, like a current breast cancer, right? You wouldn't put estradiol into that person. They're generally going to be deprived of estrogen trying to shrink or before they're removing the tumors and that sort of thing. So it's a lot to think about, and the benefits, I think some people will play those up, if they have a book to sell or they make money by prescribing them or putting pellets in people and those sorts of things. So I think that there are some real benefits, and as far as the timing goes and the typical pattern of perimenopause, we can talk through that and what symptoms make sense there and what symptoms are probably something else, because it is just so broad. And I think you said it great when you sent over the 5,000 symptoms of perimenopause, which is what a lot of people are sort of claiming.
Absolutely. And that's one of my fears is, like you said, people are looking for an answer. They want an answer and they want a thing to fix it. And it's just never that easy with our health, and especially as a woman. But that's, we don't want a young man because he's maybe thin or doesn't have a lot of muscle on him to start testosterone at 19, do we?
Right. No, I would not recommend that.
Okay, correct. And we can talk about more of that later. But that's what I'm hearing in this menopause space is starting earlier for protection. And they're taking this timeline back of perimenopause starts 10 years before the average age of 50 or 51. So because you have these symptoms, let's go ahead and start HRT in your late 30s and early 40s. So that was one of my other big red flags, is like, why would we want to be taking exogenous hormones? Because isn't that the problem with birth control? Part of the problem is getting that system kind of confused. But instead of finding out why your hormones aren't functioning correctly, which is the underlying autoimmune issue or thyroid issue that's gone for years without being detected. So what's your opinion on starting someone in their late 30s and early 40s on HRT?
Yeah, I mean, most likely they've already been on HRT in the form of birth control, right? It's just synthetic versus the estradiol, progesterone, testosterone that's there naturally. And for some people, those are medications that improve their quality of life. For some people, it's something where they're using it to, they're 16 and like you said, it sort of masks their PCOS, and then they come off of it 10 years later and they're like, the birth control pill gave me PCOS. And there can be some delayed recovery. Most of the time, things do bounce back. They're not terribly suppressive long term, but there has to be a reason to start the HRT, right? It's not that, in the same question for men and women, it's like, what age do I start TRT or what age do I start HRT? And if you take just like progesterone, for example, like if a woman is becoming more sensitive to the luteal phase shifts in progesterone, there can be a reason to add just progesterone by itself. You don't have to add all three hormones back in at the same time. I recommend not doing that, because then you have to go back and play detective if a side effect happens. But adding in just progesterone to sort of smooth out that luteal phase, rise and then fall in progesterone. Because some women, and they'll say, I don't feel like myself the second half of the month. And some women are sensitive to just the rise or just the fall in progesterone. And some women are sensitive to both. So really, more than half the month, they're not feeling like themselves. So you can add progesterone and even pregnenolone, which is over the counter. It's going to convert into some of those downstream neurosteroids to help with that destabilization of the GABA receptor, which same thing that Xanax binds to. It's sort of thinking of it as a calming system in the body. And you're basically, think of it like shaking that system up, and it's like, whoa, what's going on here? So that could be a reason, right, for progesterone. Or if sleep quality is not where it should be, progesterone has a drowsiness or sleep-inducing effect. So it can help with sleep onset and sleep maintenance. Sleep hygiene is going to be far more important than whether or not you're taking progesterone. But those could be reasons to start that specifically. If you're looking at estradiol, I see this mistake. I would say probably the most common is a woman is in, perimenopause, which can be extremely broad. You could call that 10 years prior to menopause, but they go in and they complain of some, their hormones aren't balanced is their chief complaint to their OB. And the OB says, yeah, you're in perimenopause. Let's put you on some estrogen. And things get worse, not better, because you can have an increase in estradiol as you're in perimenopause. So a common presentation is that, it sort of starts to trickle down and it's a little lower, a little lower, a little lower. Adding back some estradiol, not a bad idea in that case, so that you're in that ideal range for your bone density and brain health and heart health and these sorts of things. But if you're already, let's say, instead of an average of 100 to 150, if your levels are 250 and you add more estradiol to that system, that's going to generally make you feel worse, not better. So that's a common mistake, because we don't measure serum levels a lot in the traditional system. Now, I'm always titrating to serum levels and symptoms, sort of looking at the two and looking at the health goal. It doesn't take a lot of estradiol to relieve hot flashes, but you have to get to a certain serum level if you're looking at protecting the bones, or at least not having any negative effects on cognition and maybe some protective effects in people who are predisposed to dementia. That's something that's been shown with certain serum levels. And it's just very rare that someone in the traditional system is going to look at levels. They're just going to look at doses of generally a patch or a pill or something like that.
That's another thing that got me too, was that's the narrative is we don't need blood work. We just look at symptoms. But as you said before, there's 50 other things that can cause the exact same symptoms of what you can associate to perimenopause. And then the whole issue of, testing for estrogen in the system is a one glimpse on that day, on that hour thing, but you have to, I think, get a baseline perhaps, like how when you hear a doctor say, we don't need to test your blood levels, you just need estrogen. What's your response to that?
Yeah, I mean, I think that's some old school thinking, if you're putting it kindly, but you're, harming patients if I'm putting it in a more blunt way. So that's one of the reasons that the patch is, my preferred route of replacement, because you're going to have very steady levels. Once it's been on for several weeks, you're basically going to be in a fairly tight range, and we know how much you're getting. Whereas if you're using a pill or a troche or a pellet, you're going to be wildly different. Right before the dose, right after the dose, right before the pellets are put in, right after they're put in, and it's hard to gauge exactly how much hormone someone is getting. So if you're looking at in the variability, I know you sent over this paper ahead of time looking at, the differences in how women absorb it, and, looking at that, 25% of women don't get an adequate level on the highest dose of a patch. And it's not uncommon that I have women using 2 patches, and we have to, wrestle with insurance to get that approved, because they're on the max dose. Why are we going to pay for another patch? And we send over their symptoms they're having, the serum levels. There could be different ethnic differences in absorption of the estradiol. So we do have to wrestle a little bit to get those things covered, and even brand to brand, right? If you go and get it one generic one time, you get a different generic next time you get the patch, you can feel totally different because you're absorbing it in a totally different way. I mean, when drugs are developed and they go generic, the original manufacturer doesn't just hand over the recipe to the generic company. They say, well, you have to figure that out. And then it just has to be within about, 80 to 125% of dose exposure. So you could be getting 20% more or 20% less exposure to estradiol on paper, but that doesn't account for the differences in, a large group of individuals. So these are typically smaller studies. And when you're looking at the millions of people that are using them, you're going to have outliers on both sides of that as far as absorption goes.
And in your opinion, in that paper, what are some other things that would prevent, like if you have this woman taking the exact same dosage as this woman, what are some of the factors that would keep her from getting that circulating estrogen in the body with the exact same application?
Yeah, it's just the skin permeability. And usually they use some permeability enhancers. The estradiol is sort of in that adhesive matrix. And if someone gets, let's say, an inflammatory reaction from the adhesive, that's not uncommon. The Vivel brand seems to be the best from what I've heard in terms of not getting that. But if you get inflammation and you're having more blood flow to the skin and your body's sort of shuttling resources there, you're probably going to pull more of that hormone into the serum. That's one example. The binding proteins, I think about this more with testosterone, but there's also some binding of estradiol, where if a woman has a lower level of sex hormone binding globulin, which sort of, regulates metabolism and helps with delivery of the hormone around the body, it's thought of as being relatively inactive while it's bound. Now, if you have a lower level of that, then your serum level is going to be lower, getting the same tissue effect that perhaps a woman with a higher level of that protein is going to have. So if I, see blood work and a woman has an SHBG of 20 and she's insulin resistant, probably not a good idea to put that woman on testosterone, because she's going to be more prone to androgenic side effects like acne or hair loss, even voice changes if it's done over a long period of time, or if it's a pellet put in that you don't have control over adjusting the dose. So looking at the baseline is really important to see what is somebody's starting point. What hormones do they need? The timing during the menstrual cycle is also important. You can have a peak estradiol level that's 400, and then you can have a level that's like 50 or 60 during the early follicular phase, so like during the menses. So like knowing like when that was drawn and having a provider that actually takes the time to say, hey, let's check this, about day 21 mid-luteal phase, so we can see if we catch that progesterone spike. Because it's very easy for inexperienced providers to just check a random day and say, yeah, your progesterone's low, so we're going to put you on progesterone, when that's actually the normal state in a follicular phase, is to not have much measurable progesterone in the system.
What percentage of providers do you think are testing SHBG?
I mean, that are actively prescribing hormone replacement therapy, I think it's probably single digits, probably less than 5% would be my guess.
Back to myself as an example, when I was in my early 40s, again, I'm always having a plan. Like, okay, I know this is coming. I was told I was going to go into it early. I need to have a plan. So I went to another reputable, very well referred clinic, and it was two OBGYNs that turned functional medicine doctors. So I thought I was good to go. So I walk in and, told her my hesitancy of starting anything too soon, because once you do it, you need to stay on it. I'm like, I want to see what I'm doing. I want to see how I am right now, see where things are. And she was turned off by the fact I was questioning anyway. But I walked in, having heard all these podcasts of, SHBG and do this blood work and this blood work. That's what I went for, was like, I just want to do a real good, complete panel to see where I am on everything, baseline, so I can do another test in a year and kind of work my body from there and see what I need. And it turned into, well, are you going to get a mammogram? Are you going to get a colonoscopy? I'm like, that's not what I'm here for. So getting the right people to know that, and this is a very popular clinic here in Charlotte. It's very frustrating on the woman's side, trying to find the right provider. So SHBG is a thing we want to be making sure we're getting tested. What other kind of testing in this perimenopause phase and transition into menopause should women be making sure their providers are testing for, and maybe even seeing it as a red flag if they don't get that on the first visit, as like, this is what we do with people going into this phase of life. So maybe see that as a red flag and take their money, invest it in somewhere else.
Yeah. There's, from just a hormone standpoint, even the assay of estradiol that's ordered can be very important. There's one that is, if you look at the lab report, it'll say LCMS, which is a mass spectrometry assay. And there's one that'll say Roche-Clia. And usually if it doesn't say that, there's some fine print about, this more sensitive test is recommended for these clinical scenarios. And the problem is the Roche assay will tend to overestimate estradiol levels. So if you're in perimenopause or you're menopausal, you could test that and it says, hey, your estradiol level is normal, right? Which a lot of people are going to get told anyway, because the reference range is quite broad. What we look at is it reasonably close to the average, and are your symptoms correlating with that? So like I mentioned earlier, 100 to 150 picograms per ml is about what you expect for average estradiol exposure in women. It's going to be higher if SHBG is higher, lower if SHBG is lower. So that and the SHBG is very important. Looking at just serum testosterone, looking at that progesterone luteal spike. And it don't always worry if it's super high or if it's not so high. It just means that you are getting one, and that ovulatory cycles are probably happening. If people are looking at ovarian reserve, then you actually want to test about day 3, look at the estradiol, look at like an anti-Müllerian hormone, AMH. So, a lot of young women, this is just never talked about, but that can kind of predict what your fertility reserve looks like. Like one upside of women with PCOS is that they tend to remain fertile longer, even though they have more difficulty with conception. And they may have a little bit of a delay in menopause. So you may see that instead of being like red on the nose at 51, it's a couple of years later. So those are just the hormonal things to think about sex hormone wise. If you look at a lot of people, their complaint in this time frame of life, say between 40 and 60, is going to be fatigue. So you're going to check the thyroid, you're going to check adrenal function, the DHEA level, cortisol levels. You're going to look at their vitamin D status, their B12 and folic acid status, their iron levels. That's something that's extremely underdiagnosed, is iron deficiency. And that's why you get dizzy when you stand up and feel lightheaded. And that's why you're tired. And that's why your run times aren't improving. These are very common things where if you're in this traditional environment, you may check one of those each visit, right? So you have 5 or 6 visits before you find, aha, this is what it is. But that's one of the good things about these self-service labs, is people can get these panels with all these things on it. And then you're like playing whack-a-mole and you've got 5 hammers. You're like, okay, I figured out it's not these 5 things. It was this thing that's causing it. So it speeds up the time to find out what is really making you feel the way you are. And sometimes it's just as simple as taking the history. Like if I'm talking to somebody, we talk about their sleep, their diet, their exercise, and like, I'm tired all the time. And it's like, well, how much do you sleep? What is your sleep like? It's like, oh, it's great. I sleep 5.5 hours a night. And I'm like, that's probably why you're tired. What's going on? Are you waking up? Are you tossing and turning? And that opens a conversation about like, the pillar of sleep as far as your health.
Can you explain to me and us the cascade of how hormones are created? So I've been hearing a lot of people, because again, like the first reflex for a lot of providers is, I literally heard one of them say, I want to slap a patch on everyone that can tolerate it. They just slap the estrogen patch on and go. Some providers are saying, like you said, start with just progesterone. Some providers are like, look, we need to start with testosterone. In the cascade of creating and getting the hormones in the body, where does it start and how does it progress along?
Yeah, so it starts as cholesterol, and most tissues create their own cholesterol. So there's this idea that if you lower cholesterol, that it wrecks your hormones. And there may be some outliers where people see some drops in testosterone level, like in men with lipid lowering therapy, but they're generally pretty small. And it's actually the HDL, so what we used to call the good cholesterol, that would be delivering the excess cholesterol to like a Leydig cell in the testes if there was a deficit or a lack of production. And the stimulus, it starts in the brain, right? So you have your pituitary gland. They call this the HPTA in men or the HPOA in women, the hypothalamic pituitary ovarian axis. So those signals get sent down and you have a corresponding amount of hormone that's produced. And there's a multitude of enzymes that are involved in converting this cholesterol into the target hormone, and the testosterone being converted into estradiol, which happens in women as well. And then this sort of rhythmic production of the progesterone. So like stable hormones premenopausally is kind of a myth, because if you look at the chart of like the LH surge and the progesterone spike and the high estrogen and the lower estrogen, there's nothing really stable about that. So this idea of like you're going to balance that and it's going to be like a flat line, that's not what happens naturally, and that's not something we want to try and engineer necessarily. So when you're thinking about those things and the hormones, you're sort of looking like, okay, where's the cause of the lack of hormones, or what's the cause of the overproduction? So is it stemming from the pituitary? Is it stemming from the sex organs themselves? Is it sort of this type 1.5 that's in between, where it looks like the signal's being sent appropriately, but it's just not, the body's not responding in the way we would want it to. It's not sensing that there's a deficiency there. Generally in women, you're going to see this trajectory of the LH and FSH going up and up and up and up. And you can sort of use that to take a guess at when menopause may be more likely to occur. But you can sort of have this sputtering of the ovaries as well, where they sort of quit working for a little while and then they start producing estradiol again. But that rise is the pituitary sending a louder and louder signal to those organs to produce the hormone, because it's saying, hey, I sent this signal. There's not enough estrogen around. Like, you need to produce more. And it just keeps ramping up that signal, ramping up that signal. And that can actually drive sometimes more testosterone production, but you don't see the estradiol go up. So it's not uncommon that in this perimenopause or in menopause, women feel like they're more masculine. They may notice like some chin hairs pop up that were never there before, or their body hair is growing a little faster. They're like, what's going on here? So that can be an example of why that might happen, and generally how those systems in the body communicate.
I had a very close friend of mine, it's a couple of years older than me, started going through all these things and went to her OB, and the protocol that she was given was birth control, HRT, and testosterone all at the same time. Can you talk about how bad that is?
Yeah, it goes back to my don't start a lot of things at the same time. That's something I really try to emphasize with my patients. Sometimes they have 5 or 6 complaints and they're like, I want to start 5 or 6 supplements and fix these things. And we have to prioritize, okay, what are the 1 or 2 things that are bothering you the most? We can check in a few weeks, 6 weeks, depending on like what the problem is. Make sure that, okay, this is going well. There's not problems that are happening. And then you move on to the next one. So, if someone is going on a, contraceptive, that it's not always a terrible option as a bridge, especially if someone is just ramping up and ramping up and ramping up and having too much estradiol production. It's a way for us to kind of put the brakes on the pituitary sometimes. I'd say it's rare that that's the case, but sometimes it is the case. And then if you're looking at like starting HRT, starting testosterone, if there's a woman who's, say, newly menopausal, and we can actually see this in blood work sometimes, where Estradiol, is average, 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 and it just falls off a cliff. And it's like, oh, now it's 0 or less than 5 is how it will show up on your panel. We can say, yep, your, ovaries have, this hormone production has fallen off a cliff. It's different than in men where it kind of trickles down. Then, generally starting with estradiol and progesterone, not even on the same day necessarily. I'll have women, it's like, hey, let's go ahead and put this patch on. A week later, you start your progesterone, because you're not going to get endometrial hyperplasia and uterine cancer in a week. But I want to know, how does the estradiol make you feel? And then a week later, how do you feel now when you've added the progesterone in? And we talk about the things to watch for with estrogen, the things to watch for when you add in the progesterone. That we were kind of looking at these pieces separately. Maybe 2-3 months later, we come back, look at the levels. If we need to make adjustments, we do. And then we can talk about, is there a reason to add some testosterone to this? And sometimes women are just asking. Sometimes they're saying, hey, I'd like to start testosterone. And my question is, so why? What are you expecting to get out of it? Because I think the benefits there are sometimes oversold as well. It probably is one of the more reliable ways to increase libido in women, but it's not 100%. It's probably 60% of women that are going to get that benefit. Some women, they can have a extraordinarily high serum testosterone and not get that libido improvement. And they're like, what's wrong with me? And it's not you. It's just sort of the way your androgen receptors are programmed. Not everyone is sensitive to that and gets that benefit. And just like with sleep, not everybody gets fantastic sleep from progesterone. It's the most likely outcome, but doesn't mean 100% of people get 100% of the benefits, which is somehow it's sometimes painted like that in people who are trying to be very anti, traditional medicine at all, never go to any doctor that doesn't put you on HRT kind of thing.
Mm-hmm. You talked about pellets earlier, so let's have that discussion. I'll give you my opinion from my hands-on experience. So what I see in practice. So several of my clients have done them. Again, being a body worker, a majority of people do not have good glute mass to begin with. And I'm concerned about that injection site on that thin tissue right around that the sacrum and the hip joint, thin tissue, like every 3 to 4 months, getting an injection in there. And then scar tissue forming over, I don't know, we're going to take this for the next decade or two. And then I've had several of them have it, is the proper term, exclude themselves. So the pellets literally came out. Yeah. Yes, and got infected. One of my gentlemen tried them and they had to put 10 in at one time for him to get the number that they were aiming for. It was horribly sore, painful, a CrossFitter, so it couldn't work out. So that was a mental and emotional, problem. And then for several of my women that have been on them for a while, because they are convenient, you don't have to think about applying a cream or whatever, or doing a troche. I'm starting to notice in really weird spots, because I see everything. I see and feel everything. And they're starting to get black hairs around their arm and shoulder and their low back that they didn't have before. But I don't think I would ever do a pellet. What's your opinion?
Yeah, I don't do pellets. My joke there is that I might do it in a pet for convenience. If I was going to put a dog on TRT and didn't want to think about it, give a shot every week. But I wouldn't do that to a human. Now, there are some people who they like their pellets, and that's fine. But it best, it's like a unnecessary surgical procedure, minor surgical procedure, but something you go in and get done every 3 to 6 months. And it's not a great place to start. If I'm making the case for someone using pellets, they should use a shorter acting form of the hormone first and make sure that their body reacts well with it, rather than something that's going to be in their system for 3 months and not be able to be taken out. Especially as women approach the age where things like breast cancers develop, right? You don't want a lot of extra estradiol from that in there to grow the cancer faster. It's not going to be causative necessarily, but it just sort of makes me uneasy thinking about it. And the pellet extrusion rates are, I think, above 10%. So, 1 out of 10 people is going to have some of these pop out and can't really exercise for several days to a week afterwards, as far as doing functional things like squatting down or, certainly most leg exercises. CrossFit is, very heavy on hip hinging and squatting and things like this. And, it has a lot of downsides. And then the upside, I guess, is the convenience. And the upside for the providers that are putting them in is just, I think, a financial one. or it's sort of cookie cutter where they are able to not really think about it and they kind of put everybody on the same protocol, which is kind of counter to where my intuition is looking at people as an individual. And, it's, sure, some people are going to end up on the same dosages of things, but it really varies a lot from person to person.
And touching on the cortisol factor that you mentioned earlier, that's another thing that I hear from every woman is I have high cortisol. That's why all these things are happening to me. What's the reality of our cortisol? And cortisol isn't bad, just like there's not technically bad cholesterol or all these other things. Like that's another thing that made me not trust a lot of health providers is when they classify a hormone as a woman's hormone or a man's hormone. That just from the very beginning, I'm like, well, I don't trust you now. So what is the whole story? Not the whole story, but give us a little bit of the information behind cortisol.
Yeah. Yeah. And like the male and female hormones, we had a commenter on our social media who said, I asked my OB, well, if testosterone is a male hormone, why is it in female bodies? And I sort of got a kick out of that because people are asking these questions now.
Yeah.
And cortisol, I think is, again, it's something that a lot of functional medicine clinics will say everybody has cortisol issues, and a lot of traditional medicine clinics will say nobody has cortisol issues. And the truth is somewhere in the middle. It skews towards less people having a cortisol issue than think they do. Like the fat gain around the midsection is probably not cortisol. It's probably more to do with lifestyle factors. Or someone's hormone profile as far as sex hormones rather than cortisol sort of independently doing this. Now, you can see some high cortisol states like Cushing syndrome where people truly have like pathologically high cortisol that's creating a myriad of problems. And you can see like stress or training induced elevated cortisol where people are like, if you're in a block of training for a marathon, you probably have quite a bit of extra cortisol. And that's not going to be particularly helpful for sparing muscle while you're in this training block. So you have to be still concurrently lifting weights and strength training in conjunction with that to preserve the muscle because the cortisol is going to have a little bit of a catabolic effect. And there are ways to sort of push back against that. But I would say that probably more than half of people who are taking an adaptogen or something to lower cortisol, they aren't necessarily getting the benefit because of lowering the cortisol. It may be because it's a combo product and has some other relaxing things in there. It helps them sleep. So it's not necessarily all bad, but their understanding of the effect may be a little bit misguided.
Another thing that I've heard recently was with men and women is cycling your HRT. Have you heard of doing that? Is there a difference between if you put a patch on and it wears down by the time the month ends? Is that not kind of cycling, or is there a whole nother like concept of cycling HRT or testosterone for men?
Yeah, so on the male side, I think it comes from like old school bodybuilding where people would do a cycle and then go off to let the body recover. And realistically, a lot of those guys are not staying off long enough to truly recover. In some cases that can take 12 months if you're doing nothing else to speed the recovery. But maybe in their off season, they would take 8 or 12 weeks off and then go back on a cycle. So that's not really common practice anymore. We're moving towards more hormone stability, more frequent injections, subcutaneous, so minimizing scar tissue, which I know you mentioned you'd seen as a massage, being in the bodywork space, sort of feeling and hearing people complain about scar tissue building up with these. They call it getting harpooned with needles, that are much larger than is really necessary. And then on the female side, there's not necessarily a downside or an advantage to cyclical HRT. And usually that's referring to just the progesterone component or progestin component. Other than for some people, either culturally or spiritually, it's important for them to simulate a cycle and have a withdrawal bleed. And it looks like whether you use continuous or cyclical, the health outcomes and the risks there are basically the same. But I would say in my experience, more women than not sort of prefer to not have to worry and think about bleeding. It's like, they're like, oh, this is one of the good things about menopause is now I don't have to necessarily be always thinking about this or prepared for it every month. So I don't have a strong preference one way or the other. It sort of just depends on where people's values are with that. But for men, it almost never would make sense to do something cyclical unless they're coming off for a period of time to optimize fertility, which you can do while you're on testosterone. A lot of times it just depends on the financial situation because some of the ancillary medications to have fertility while you're still on testosterone can be expensive, and it can be a little bit of a burden to be injecting. Instead of doing 2 shots a week or 3 shots a week, now you're doing 10 shots a week. And, they don't want to be as much of a pincushion, so they'll just cycle off, recover fertility, and then, go back on the testosterone.
And where should men be injecting their testosterone?
My preference is subcutaneous or maybe shallow intramuscular. So if you look at, depending on their body fat level, you can do like the upper outer corner of the glute there. Usually people are going to be able to reach that and have some fat there. The outer middle third of the thigh, you can rotate through several sites there, pinching up some fat or even, pinching up some muscle if you're doing shallow IM there with a little bitty insulin syringe. It's not going to build meaningful scar tissue. And then some people will do the glove handles or the abdomen, as long as you're about an inch away from the belly button. And some people avoid that in the summer just because every once in a while you do get a bruise, and cosmetically, if they're at the pool or whatever, they want to avoid that. And then they'll go back and, rotate through those sites. Generally, you just don't want to be injecting the same exact spot over and over and over again. You want to kind of rotate through, let that area totally recover before you're putting a needle in it again.
And if a man is getting nerve pain when he does his injection, what does that mean?
It means he should talk to his prescriber and see what's going on, probably go get an evaluation of his injection technique, or stop injecting that area if it's specifically causing that electrical nerve pain. That's not a good sign.
One of the articles I sent you was Dr. Vonda Wright's paper on the musculoskeletal syndrome of menopause. So again, this is another thing I hear in clinic every day is I have the musculoskeletal syndrome of menopause and I'm starting my HRT and I'm hoping that's going to help. Again, it's like, is it a time factor of I've been protein deficient for decades. I haven't strength trained for decades. I've been on histamine, steroids, chronic antibiotic for decades. So in my opinion, of course, everything's going to hurt. And again, do all the HRT you want, but if we don't get the systems healthy, you're still going to have the same result. You're just going to have maybe more balanced hormones. That's the way I look at it. So did you have a chance to look at that paper?
Yeah, and I've heard her speak on some things, and there definitely are changes that happen in connective tissue and in muscle when estrogen is withdrawn. So I don't want to necessarily minimize that, but you could just as easily call it a musculoskeletal syndrome of aging. And just by nature of the way most people age is not prioritizing protein or resistance training. So if you have atrophy of muscles around a joint and weakening, you're going to have more joint laxity. You're going to be at a higher risk of injury. It's not that menopause necessarily did that to someone, but on the opposite end of the token, there are people who, let's say, take one of your CrossFitters, right? A gal that's been doing this a long time and knows her body and knows her recovery and her nutrition is dialed in. And then all of a sudden she can't do those workouts every day anymore. She can only train twice a week. She knows something's changed, and estradiol directly does improve exercise recovery. That's probably one of the reasons that women can recover a little bit more quickly than men from those CrossFit style high intensity workouts, is because they have higher levels of estradiol than men do. Now, the absolute strength and sort of things like that, the males biomechanically are going to have some leverage advantages there. But if you're looking at just the recovery standpoint, estradiol, generally good for the connective tissue. Your joints are going to feel more lubricated. Your muscles aren't going to be sore as long after exercise. Those things do matter. And even with, body composition to a small degree, with less estradiol or zero estradiol, you're going to tend to accumulate more midsection and visceral fat. That's something that will happen. That is a true, you could call it a syndrome of menopause or a syndrome of a lack of estrogen. But as far as, like you said, what foundation did you build, like the retirement analogy or deposit analogy you used earlier? If you're not building that foundation, so getting enough bone density, getting enough muscle mass to sort of make it through your, physical and health sort of retirement years, you're not going to be in the best scenario. You're going to be more prone to all of those things that happen with menopause.
That's exactly what I'm saying. And I think it's just like because people always want to put me in the box of you only like believe in natural things. And I'm like, no, that's not it. It's which one when. Like I want you to do everything that's available that's going to help you be a thriving, healthy individual. But that's exactly the dynamic that I'm seeing on my table with a lot of women is they are now of the age, have the time and money to go be doing exciting, wonderful, beautiful things, but they can't because they feel horrible. But they say, I started HRT, so I'm hoping all this is going to get better now, when they have no muscle mass on their back. I know I don't even ask anymore, are you eating enough protein every day? Because everyone always they over report their good behaviors. I say, what did you have for breakfast? And that's so telling because most women either don't eat breakfast, and I don't care about exactly breakfast, but before 1 o'clock, because I hear a lot of like, I just don't really feel like eating in the morning. So I usually eat it the first time around 1. I'm like, okay, that's fine. But like between 1 and 6, tell me what you're eating. And it's never enough. So that's my fear for people is they're putting so much stock in this one, if we just like with investments, you should have like a bunch of them because one of them is going to not do well. They're putting all their stock in the HRT. And I'm like, yes, do all the HRT, but you're not doing the other things that are still going to make you be in a diseased state. So with the musculoskeletal side of it, if you, for example, like with my children, I'm always in their ear trying to, help them stay on the right path. If you were going to lay out a game plan for a woman, if you want to enter menopause with the best conditions possible to have the least amount of symptoms, because I always correlate health to not health isn't the absence of sickness or disease. It's the ability of your body to recover when you come into contact with those things. So, symptoms are less exacerbated and last for less time. So if you were going to create a game plan, let's do 2 game plans. The first game plan would be for the woman that, again, yes, do all the HRT, but what is it on your list of things you would have someone do in the years coming up to menopause that would give them the best experience in that transition versus if you were going to make a game plan for a woman that's going to have all the different names that they're calling this experience, but has the worst outcome, the earliest symptoms, the most miserable experience. Like lay those 2 game plans out for me.
Yeah. So if you're looking at the former, right? So someone is preparing to go through menopause, and a lot of these recommendations are probably going to be the same, right? You need to build a strength base. And if someone is not familiar with resistance training, weightlifting, which a lot of people they just didn't grow up with that. Now I think culture sort of shifted and it's more normalized for everybody to be lifting weights, which I think is a great thing. And, getting a trainer and learning how to lift safely and the effective exercises. So things that are targeting multiple muscle groups. So if you're doing, like just bicep curls, right? That's not necessarily a very functional movement. There can be cosmetic benefits and it's important. People want to feel good and look good. But things like a squat or a leg press or a belt squat, upper body movements where you're doing something like a lat pull down or a seated row, these sorts of things that are really engaging a lot of muscles at the same time, it's going to be your best return on investment for your time. And you don't have to do it a lot. A lot of people I have start with once a week. And once they're recovering well from that, go up to twice a week. And you can make progress and build muscle and get stronger and improve your bone density just by that small amount of time. And then on the aerobic side of things, if you want to be able to quickly move across an airport when you're 70, you need to have a pretty good aerobic base, do some cardio. And I don't care too much about making sure you're precisely in zone 2 and you don't spill over into zone 3. It's more about getting people moving to start, but just, walking the dog once a day is probably not enough to get people where they actually want to be if you're forecasting their decline that will inevitably happen. You're looking at, okay, you need to do some intentional exercise that's actually getting your heart rate up. An easy one is to do 75% of your cardio training at 75% of your max heart rate. That's not going to feel too hard. It's not going to impact your recovery from your other exercise. And if you're looking at very time intensive, people who are like, I don't want to do 2 hours of cardio a week, you could probably get away with, a little over an hour of cardio a week if it's all high intensity interval training, right? Which, if people are doing like CrossFit style training, the heart rate is certainly going to be elevated very early and throughout most of that workout. So there can be a lot of different ways. And, CrossFit, of course, technique and injury risk are there. Technique is very important, but that's probably the best way for someone to like stack all of those things together. But it's not for everybody. Some people are going to get burned out, or it's too technical, or they heard about someone that got hurt doing it, they stay away from it, and that's fine. There's a lot of ways to get that same end result. So that's just the same things would apply to the latter case, where a woman who's going to go through a easy menopause or a difficult menopause, they're both going to lose estradiol unless they replace it. Perhaps that woman with the early symptoms would actually benefit from some earlier initiation of hormones, depending on where those are in the blood work. Or if that woman already has osteoporosis before she went in menopause, maybe the birth control pill limited her peak bone density. The bones didn't get as strong as they otherwise would have. A small factor, but it can make a little bit of a difference. And she didn't, do things like high impact exercise, jumping, landing, lifting weights. It doesn't have as much bone density in reserve. We want to think about, really emphasizing that high impact exercise to give the body a stimulus to hold on to and to build new bone going into menopause. Because you can still add back bone density. It's much harder than when you're 16 years old, but you can still add it when you're 50. We do DEXA scans. We can repeat those annually in people and see improvements. Important to note that it should be the same machine, so you're making an apples to apples comparison when you're looking at last year and this year. But there can be supplements and adaptogens and things for basically what that symptom is of this hormonal chaos, or maybe the sensitivity to those hormonal changes that a woman is having. So the hormone profile may be perfectly normal, but she's just now very sensitive to that rise and fall in progesterone, whereas when she was 20, maybe she had a day or two of PMS, didn't really think about it. Now it's going to be much more broad. And I've seen that happen. And we don't know exactly what the underlying root cause is there, but people are just more sensitive to that GABA destabilization. So it sort of feels like they're withdrawing from Xanax for a couple of days to a couple of weeks out of the month.
Mm-hmm. So my last question is going to be kind of centered around birth control. And you have said this many times. I agree completely. We're not anti-birth control. You can't take anything without some negative impacts. But as far as the Women's Health Initiative that did this whole no HRT for all because of the study research that it did, why was the answer from that study not no birth control for all, since what looked like the evidence showed was that progestin was the problem and oral estrogen was causing the biggest problem?
Yeah, and that's what the data suggests. And it got spun into this weird PR thing where I believe there was a press release before the authors had sort of deliberated and come to a consensus statement. So it created a lot of chaos. And then I guess rather than flip-flop, the people who were behind that study sort of just held the line and were like, yeah, estrogen is bad, causes breast cancer. And it's not necessarily a relevant study anymore because it was a synthetic estradiol, synthetic estrogen, conjugated equine estrogen, and synthetic progestin, right? Medroxyprogesterone acetate. That's something that was used, and this is not really prescribed by many people that I know now. I know it is still prescribed to some degree, and sometimes it can be used to get control of like severe heavy menstrual bleeding, talking about the progestin component of that. But as far as an HRT protocol, nobody is really on that now. It's just poor messaging and harmed a lot of people. And what I will say is I think there is, with estradiol, I mean, I'm not going to say there's zero risk of increased breast cancer, because if you have estrogen around, the breast cancer that develops is more likely to survive. But it's like 1 or 2 cases out of 1,000, and it's very detectable and curable. You could make the same analogy for a male. It's like, well, if we just castrated every male at 51, then there'd be less prostate cancer. That doesn't mean that testosterone causes a prostate cancer. It just sort of allows it to proliferate if the circumstances are right. And again, these things are very detectable and treatable now, and we don't overtreat them as much as we used to. We used to pull prostates out of anyone who had a hint of prostate cancer going back 20 years, radical mastectomy, and now things are done more like lumpectomy or just much less invasive and aggressive treatments that have better outcomes for people's life and quality of health and that sort of thing.
And I believe the same thing happened to men too with testosterone. Like there was a study many, many, many years ago that showed an association with cancer, and they kind of did away with testosterone for all. Didn't that happen with men as well? Kind of the same situation?
Yeah, so the heart disease risk and then the prostate cancer risk. The heart disease risk actually just got removed. I think it used to be a black box warning on testosterone, and now the Traverse trial that was published came out and said that actually, we don't think this is a risk for heart disease, like in a traditional sense, like looking at plaque building up and heart attacks and strokes and those kind of serious outcomes. It can still enlarge somebody's heart if they're taking too much, and if your blood pressure goes up on it and you don't manage that, it can still accelerate problems. But yeah, with prostate cancer, for a while it was thought that, this is why men are getting prostate cancer. It's going to be like fuel on the fire if men get prostate cancer. And this is still a little bit debated. There's a question about the saturation point. Is that 200 nanogram per deciliter really having the same effect in the prostate that 1,000 nanogram per deciliter is? And people kind of go back and forth. And, when a man does develop prostate cancer, you're going to withdraw androgens. And then it's not always a lifetime of never going back on testosterone. There's some papers and trials looking at anywhere from 6 months to 5 years after like remission, right? Prostate cancer is gone, of putting these men back on testosterone. And it doesn't seem like it's causing, it's not causing a recurrence. It's not causing another prostate cancer, but it is an androgen dependent tumor. So with more testosterone, in theory, it would grow a little bit faster. And again, we don't know 100% yet on this sort of saturation model that's there. But it's something that's very easy to screen for. It's a simple blood test, and we're getting MRIs before we do biopsies, and it's much less invasive and leading to much less complications. So, this is sort of this historically thing in medicine where we're overreaching and overstepping, and now things have scaled back a little bit.
So all in all, I think the most important thing is for us to find the right provider that can help us navigate these strange times. So you and your clinic, you're nationwide with your testing and availability?
Yeah.
Okay.
Not personally, but between our providers and physicians we do have coverage in the 48 continental United States. And we offer telemedicine. It's very common for people to come into Kansas City, see the clinic and see us to establish care, and then have follow-up care via telemedicine since they've seen us and established in person. I would say that's what most people do. But we do have a lot of state licenses and can offer virtual care, telemedicine in this current era we're in. And yeah, I'm James O'Hara NP on Instagram, co-host of the Gillett Health Podcast. It's on all platforms. We try to put out good actionable health information for people. And, that I'll add the obligatory sarcasm warning. I tend to have a pretty dry sense of humor, so I may say things that sound like, I don't know if he was serious or not.
Well, you have bells now, right?
That's right. Yeah, yes. Our editor catches most of those and a little sarcasm dinger and counter there. But we try to put out good information for people, have a bit of fun with it as well. And answer questions that people ask from time to time. So
all in all, there's no reason for us to live miserably in our second stage of life, right?
Yeah, I think mindset is super powerful. And I forget the exact verbiage you were using at the beginning, but sort of the sick mindset people can get into where they're like, oh, I've just always been this way, always had this problem. I think it's important to inspire hope in people, being realistic, of course, but, people can always build towards better health regardless of their starting point. And, empowering people, giving them the tools to do that and seeing them make progress through the work they're putting in. That's one of the things that I just really love doing day to day. Awesome. Well, James, thank you so much for your time and information you've given us today. I hope that you will continue to see a